myeloma patients. Quite frequently, high-risk multiple myeloma patients require more aggressive treatment in order to treat their myeloma successfully. Daratumumab has been key to progression-free survival in relapsed and refractory myeloma, but how does it fare with high-risk myeloma versus standard risk? Dr. Luciano Costa has been working on clinical trials with teams to find out the answer to this question and has more insights about daratumumab and treating high-risk myeloma patients to share with us today. It is my pleasure to introduce him to you. He serves as the Associate Director for Clinical Research at the O'Neill Comprehensive Cancer Center at UAB. Dr. Costa obtained his MD and subsequently PhD from a university in Sao Paulo, Brazil. And then from the University in Sao Paulo, Brazil, and then he trained in hematology and medical oncology at the University of Colorado in Aurora, and in blood and marrow transplantation at the Mayo Clinic in Rochester, Minnesota. Prior to joining UAB, Dr. Costa was an associate professor of medicine in the Medical University of South Carolina, where he co-chaired the Protocol Review Committee at Hollings Cancer Center. He was recruited to the O'Neill Comprehensive Cancer Center in 2014 as a senior clinical investigator and currently directs the multiple myeloma and the immune effector cellular therapy programs. His primary research focus is the development of new therapies for plasma cell malignancies. Dr. Costa leads several multi-institutional and international projects exploring new cellular and immunotherapies and minimal residual disease in myeloma. He is regarded as an international leader in the field with more than 200 peer-reviewed abstracts and publications in high-impact journals such as Blood, Leukemia, the Journal of Clinical Oncology, and the New England Journal of Medicine. Not to mention that we hear from Dr. Costa's patients frequently about how much they love him and appreciate his care. Dr. Costa, thank you for taking the time to be with us today, and we're looking forward to your presentation.
Thank you so much for this opportunity. I always enjoy, teaching and interacting with the patients and to participate on all the activities put together by the myeloma crowd. We're going to talk about the role of anti-CD38 monoclonal antibodies in the treatment of patients with high-risk multiple myeloma. So I don't want to be, very, too technical here, but I think we all can appreciate that the fact that multiple myeloma it's really a multi-step disease that often starts, years, if not decades, before the patient ever becomes symptomatic. You have a normal plasma cell on which some genetic events happen. The most common are some exchanges of pieces of chromosome with one another. We call those translocations. And I'm going to talk a little bit more about some of those. Or a gain of extra copy of some of the chromosomes. We call that hyperdiploidy. And those things are supposed to happen very early when that normal plasma cell goes on to become malignant. The early manifestation, if you will, is what we now call monoclonal gammopathy of undetermined significance, when the patient or the person only has the paraprotein, a little bit of the M spike in the blood or in the urine, but no manifestation of myeloma. Then is smoldering myeloma, and later multiple myeloma. As the time evolves, you not only have more of that abnormal plasma cell building up in the bone marrow, but also that population becomes very heterogeneous. So by the time a person is diagnosed, often you don't have, billions of copies of the same plasma cell, but you have billions of copies of that initial plasma cell plus billion others of some cells that have modified, even further. So think of this as being the more to the right you go, to more advanced myeloma, you have a more genetically unstable and diverse, environment. And why is this important? It's because, as I mentioned, the translocations happen very early. as well as hyperdiploidy. But there are some things that happen later on, particularly deletion of chromosome 17p, where the gene called p53 is located, deletion of chromosome 13, mutations on that gene p53, and later on, gain on extra copies of the long arm of chromosome 1 or 1q gain, or losses of the small arm of chromosome 1 or 1p loss. So, and that is kind of important because those are also markers of high-risk myeloma. So the theme that is appearing here is oftentimes those genetic changes that we identified are high risk, they're really secondary events that happen as the myeloma evolves. The challenge is some patients diagnose myeloma at a much earlier stage, sometimes even on the MGUS stage or the smoldering myeloma stage. But not uncommonly, people present when they already have all those secondary abnormalities. You have a more genetically unstable tumor that we now recognize as being high risk. So I have been talking, I'll be talking a lot about genetic changes. So mostly what we're talking about is chromosome abnormalities. So many of you may know, our genetic material is packed in 23 pairs of chromosomes that carry out the genetic information. And even though myeloma is not an inherited cancer, it's not a hereditary cancer, essentially every cancer is a genetic entity. There's some changes that happen at the DNA level on that plasma cell that helps it become malignant and behave malignant. And sometimes those changes are sudden. They are like one small mutation. But in myeloma, oftentimes those changes are pretty big, and they can be identified by this test called fluorescence in situ hybridization, where essentially you have probes of different colors. Here you see, red and green probes that tag a specific region of the chromosome that you know of. So in this particular case here, panel A, the red probe is for the region of the long arm of chromosome 1, so 1q. So instead of having 2 copies, you have 1, 2, 3, 4, 5, 6, 7, 8. So you have an amplification of chromosome 1q. So by knowing what those probes are marking and using all the different probes of relevance, you can describe that a patient's myeloma has 1q amplification, or p53 deletion, or 13q deletion, or translocation 414, and so on. So that test is nowadays very often used. Should be part of the initial workup of every patient with newly diagnosed multiple myeloma. And has become one of the main determinants of risk. Now, the other way to assess risk is by staging. This is something that I always take some time to explain to patients because it's not very intuitive at all. And now everybody knows somebody who had breast cancer or had lung cancer, which are far more common types of cancer than myeloma is. And in those diseases, and most diseases, staging is anatomic and has very direct implications for therapy. What do I mean by that? Well, stage 1 breast cancer, you have, one tumor that is, I think, less than 2 centimeters in diameter. Stage 2, you have a tumor that is bigger. Stage 3, it has gone to the lymph nodes, and stage 4 has gone to distant organs. So they are, so essentially you look, you see, you do imaging, you stage the patient, or take biopsies. And that staging has, treatment implications. Stage 1, you're going to do surgery. Stage 4, you're going to do systemic therapy. For myeloma, it's different because it's not anatomic, because the disease is systemic to begin with. It's in different parts of the body. The staging is the simplest that it can be. It's essentially based on 2 blood tests, albumin and beta-2 microglobulin. And the patients who are considered high risk are the patients who at the time of diagnosis have a beta-2 microglobulin greater than 5.5. So this is what we call international staging system. Sometimes after what we're talking about high-risk patients, we're also referring for patients with stage 3. That was done about 15 years ago, but of course that staging had a huge limitation. And the main one was that it did not account for the chromosome abnormalities, because back in those days, FISH was not widespreadly used. And as we can see on this panel here, if you take patients on the same staging, let's say patients with stage 1, for example, okay? Those patients who have this particular abnormality, translocation 414, they have a far worse survival than patients who do not have that translocation here in red, that don't have that translocation, who are here in blue. The same can be said about deletion 17p. So for each one of those stagings, the knowledge of the cytogenetic abnormality further helps us to understand prognosis. So about 8 years ago, the International Myeloma Working Group came up with a revised international staging system that takes the international stage system that I told you about, based on beta-2 microglobulin and albumin, and incorporates cytogenetics, particularly the presence of deletion 17p, translocation 414, and translocation 1416, okay? And also incorporates the presence of high LDH, or lactic dehydrogenase, which is a blood test that is usually increased in tumors that are growing very fast. And the incorporation of those 2 tests really enhance how well the revised international stage system performs. Now you have patients with revised ISS1 that have a 5-year overall survival of 82%. Most patients will be stage 2 or 62%. And about 20% of the patients will be stage 3, where the 5-year overall survival is only 40%. And that is far better than ISS. And oftentimes when we talk about high-risk myeloma, we'll be talking about patients with revised ISS of 3. Now, is that perfect? No, no staging system is perfect. Sorry, I got a frozen screen here. Give me 1 second. Because there are some cytogenetic abnormalities that were not part of the revised ISS that have since been recognized as being indicators of risk. One of them that was only recently recognized and is more and more talked about is gain of chromosome 1q. That is also recognized as being a high-risk abnormality. The other is translocation 1720, that is infrequent, but when present indicates high risk. And one that is very controversial is 1114. This one is not uncommon at all. This is actually present in about 20% of the patients. And some series indicate that to be of a higher risk, some series indicate that not to be of a higher risk. And the reason why it gets talked about is because the patients with this abnormality tend to have a very peculiar, high ranked chance of responding to a new treatment called venetoclax that is not really active or helpful in other types of myeloma. And as you can see here now, with the incorporation of of LDH and cytogenetic abnormalities, we have a much better separation between stage 1, stage 2, and stage 3. So to talk about high risk, the first challenge is how do we define high risk, right? You know, traditional staging, FISH gene expression profile, that's a test that's not very frequently used and we didn't talk much about today. We also recognize the presence of extramedullary disease. In other words, clumps of myeloma that are not in the bone or in the bone marrow, for example, in the liver or in the muscle or in the pancreas or in the liver. if they are present and diagnosed, they usually tend to indicate a more aggressive type of myeloma. And we tend to see that more and more often because we do a lot more imaging than we used to do. Nowadays, it's uncommon for a patient to have just the bone x-rays. It becomes much more common to have, for example, PET scan at the time of diagnosis that allow us to recognize extramedullary disease. There are some factors that are not disease related, but also are indicator of worse prognosis. For example, frailty. Irrespective of the biological nature of the disease, individuals that are more frail to begin with, they tend to have a worse prognosis, in part because they cannot tolerate treatment very well. And there's also that notion of dynamic risk, which is the patient, for example, who appears to be a standard risk, have a standard risk myeloma, but then receive treatment, have a response, but have a short duration of first response. For the patients who progress, who have disease progress very rapidly, that is known to be a high risk for bad outcomes in the future. And one notion that has become more and more endorsed or accepted is the idea that depth of response also is an indicator of high risk. In other words, patients who have a response that is not very deep or complete may have a worse prognosis, even if they original cytogenetic abnormalities were not high risk. So as you can see, it's very confusing, controversial, and experts are discussing all the time about what type of definition of high risk we should use. The reality is many of those things do overlap. So patients with extramedullary disease often also have high risk abnormalities by FISH. Patients who have high risk abnormalities by FISH are also usually the ones who have a shorter first remission and so on. But for the most part, the concept here that is most accepted is the traditional staging and abnormalities on fluorescence cytohybridization. And we're going to talk more about those. But why do we define high risk? I mean, the easiest answer is for prognostication. I mean, patients want to understand what to expect. And also, when you go and compare therapies, in trials that are not randomized, we say, well, I treat patients with X, Y, and Z, and this was their response, and those patients are high risk. Well, you want to be able to compare across the studies and helps to be talking about the same population. Also to recognize unique subsets. I mean, some patients may respond, some subsets may respond different to some therapies than others. And the part that is more controversial is to guide therapy. For the most part, risk in myeloma is something that we trying to understand, acknowledge, but does not affect how we treat patients. I guarantee you 99% of the clinical trials you see for myeloma patients are for all comers. They're not trials for high risk or standard risk patients, although some of those trials are being done or have been done, and we start to see results. But that's the part that is more controversial. So, speaking, one thing that is important to understand is, back in 1950s, all myelomas were high risk because we didn't have any treatments, and people die from this disease on average after 2 to 3 years. That is meant to illustrate the notion that risk is context dependent. Something that is high risk today may not be high risk tomorrow as the therapies improve. And one good example of this is how the proteasome inhibitors, particularly bortezomib or Velcade, really changed the story about 414. And this is very well shown in this study that is now more than 10 years old, that compare Velcade, thalidomide, dexamethasone with thalidomide, dexamethasone. And if you see patients who did not have translocation 414, the VTD is a little bit better, but not a whole lot, about 10% better in terms of 3-year progression-free survival. But look for the 414. It made a huge difference, went from 37 to 69%. And look at how now with VTD, the patients with translocation 414 do almost as well as patients without. And in absence of Velcade on the TD, that's much more different. So that is an example of a new therapy, in this case, Velcade, almost negating the effect of translocation 414 on the risk of patients with multiple myeloma. So keep that in mind. Those things are not absolute. They can be modified by therapy. Now, one other example where risk might come into play is when we look at the role of transplant. There has been quite a few trials that compare transplant, immediate transplant as part of the initial therapy versus deferred transplant, where the patient collects the cells, but only transplant when the myeloma comes back. And one of those studies is the EMNO2 study. It was published a couple of years ago. And as you can see here, the patients who did transplant did better than patients who did not, who received VMP instead. And that was true for patients with high-risk chromosome abnormalities, as you can see on the panel on the left. But what is more intriguing is this study had a second assignment, randomization for patients to receive a single transplant versus double transplant. And you can see here among the high-risk patients, the progression-free survival was even better with double transplant versus single transplant. And that's quite interesting because at this point, the notion, the idea of tandem transplant was really losing its traction, particularly in the US. And data sets like this made the field or kind of regain interest of tandem transplant, particularly in a subset of patients with high-risk disease. Another study that also showed the benefit of transplant is the Forte study. So this study used carprolis or carfilzomib in combination with lenalidomide or Revlimid and dexamethasone, followed by transplant, followed by more of the carprolis, Revlimid, and dexamethasone, versus just carprolis, Revlimid, dexamethasone for longer without the transplant, versus carprolis, Cytoxan, or cyclophosphamide, and dexamethasone plus transplant. And you can see is the arm that had KRD, carprolis, Revlimid, dexamethasone, with transplant had the better progression-free survival among patients with standard risk, but also among patients with high risk. And here I'm going to introduce a new concept for you. That's the concept of ultra high risk. And that is still being shaped, if you will. But what they refer to as ultra high risk here is we're also being called double hit for patients who have two, not one, but two high-risk chromosome abnormalities. Those patients have the worst prognosis in general, but you can see here they also greatly help with the use of autologous transplant. Now, the Forte study had a second randomization after the patients completed those 12 cycles or 4 cycles transplant and 4 more cycles. They were randomized to receive Revlimid maintenance, like we tend to do for most patients, or Revlimid with the addition of carprolis or carfilzomib, so double maintenance. And overall, on this study, the progression-free survival was better when double maintenance was utilized. And as you see, as a breakdown, you can see, and I want to take the opportunity to introduce you to this type of graph because that's going to be very relevant to what I'm going to show you. This graph is what we call forest plot. It really tells about a result of a particular comparison in 4 subsets. So I'll explain this to you. So if you look here in the top graph, overall, it says hazard ratio 0.63, which means patients who receive carprolis and Revlimid had about a 37% reduction in the risk of progression or death. So you see this, this graph here, is this bar is entirely to the left of 1, right? So it's favoring Kyprolis and Revlimid, okay? If you look at the international staging system, you can say it helped more patients with stage 1 and didn't help as much patients with stage 2 and stage 3. So the further to the left, the more impactful that therapy was. And you can see here the use of double maintenance helped the patients with high risk to the same extent, essentially, that helps patients with standard risk abnormalities. Now, let's get to today's topic then. You know, many of you know about Daratumumab. Sorry, I did not bring an introductory slide, but Daratumumab is a monoclonal antibody. So it's an antibody that has been artificially produced and engineered to target, to bind to CD38, which is a protein that is present on the surface of plasma cells, including multiple myeloma plasma cells. There's 2 of such antibody. One is Daratumumab or Darzalex. The other one is Isatuximab or Seclisa. They are different, have different development, and they have different approved indications, okay? Daratumumab was initially approved for the treatment of relapsed and refractory multiple myeloma. And that was based on several trials, one then called Castor, the other one called Pollux, and later a trial called Candor that add Daratumumab to a certain combination and show the patients had better progression-free survival, okay? To this day, there's 3 large trials where patients with newly diagnosed myeloma receive a standard treatment or control, or standard treatment plus Daratumumab or Darzalex. Those trials are Alcyon, Maya. Those are trials for patients not eligible for transplant. And the third trial is Cassiopeia for patients who did receive transplant, okay? So when you look at patients with standard risk disease, standard risk, okay? When you look at the Alcyon, you see here, the bar is way to the left. That means those patients are helped a lot by the addition of Daratumumab. When you look at Maya, which is lenalidomide and dexamethasone, those patients are helped a lot by the addition of lenalidomide, Daratumumab. And when you look at Cassiopeia, which was VTD, Velcade, thalidomide, and dexamethasone, those patients are helped a lot by the addition of the Daratumumab, okay? Now, when you look at the high-risk patients, it's a slightly different story. For Alcyon, you see how that square is very close to this line and actually crosses this line? That means, you know, it looks better, but we cannot be sure it's better because it's crossing the line. The same thing for Maya, the same thing for Cassiopeia. So that creates the notion, I think that was pretty prevalent about a couple of years ago, that maybe Darzalex was not helping high-risk patients. Because of that, we did what's called this, what is being presented here was led by my colleague, Dr. Geary, what we call a meta-analysis. Meta-analysis is when you have several studies that are on themselves either conflicting or not sufficient to answer a question, and we analyze them together. So essentially, you're adding the patients from one study to the next. You're adding the strand from one study to the next in order to gain more power, to gain more resolution. And that, when we did that, we can see that Daratumumab clearly helped those patients, okay? Now, it doesn't help as much as it helps the standard risk patients. But it's still a reduction in risk of progression or death of 32%. You know, who doesn't want to have a reduction of risk of having progression or death by over 30%? Very few drugs in myeloma can accomplish that, okay? Now, every single drug ever tested in high-risk myeloma that helped patients with high-risk myeloma help patients with the standard risk myeloma even more, okay? But this does not mean that those patients are not helped. They're still help, and theirs are actually the patients who need the most help. Now, let's go to a newer study, a smaller study, but this is a study completely done in the US. It's the Griffin study. Some of you might have participated on it. The Griffin study, we did this study was, about 45 years ago when we started. At that point, Darzalex or Daratumumab was not approved for patients with newly diagnosed myeloma. So we took the standard at the time regimen, RVD, or Revlimid, Velcade, Dexamethasone, and half the patients took RVD alone. The other half took RVD plus Daratumumab, followed by transplant, followed by maintenance. And when you see on the high risk, here's different. Here's the Daratumumab is on the right. So when this bar is on the right, means it helps the most. When you look at the high risk patients, it's towards the right, but it kind of crosses the line. And in terms of achieving minimal residual disease negativity. But when you extend the concept to include now the patients with 1q abnormality, which are kind of a newly recognized challenge, then you can see that clearly is to the right. So patients have a much higher chance, 2.5 times the higher chance of achieving MRD negativity if they receive Daratumumab than if they don't, if they all have high-risk disease. And why is that important? So let's go back to this IFM 2009 trial. That's a study that has more than 8 years follow-up. And you can see that some of those patients are treated with this regimen achieve MRD negativity and some did not. But the patients who do the very best are the patients who have standard risk cytogenetics and become MRD negative. But the second best are people who have high risk abnormalities and achieve MRD negativity. And then there's a huge distance to the next best, which are patients who are MRD positive and a standard risk. So as a patient, you're better off with high risk disease that becomes MRD negative than standard risk disease that remains MRD positive. So that really is a very important message, that the depth of response may overcome that initial risk understanding. And this was clear also from this study from the Spanish group showing the same thing. If you are MRD negative, it really didn't matter anymore if you were standard risk or high risk, although none of those studies incorporate drugs like Daratumumab. So what we did in our group is this trial that has recently been published called the Master trial, where we use Kyprolis, Revlimid, Dexamethasone, and Daratumumab for 4 cycles, transplant, and then we measure MRD at the end of induction, at the end of transplant. And if patients had 2 MRDs that were negative in a row, they went on to what we call MRD sure, which is treatment-free observation and MRD surveillance. Otherwise, they continue to get up to 8 cycles of Dara-KRD. And if at any point they had 2 negative MRDs, they went to observation. So the attempt here was to push patients further to get MRD negativity. But if they get MRD negativity and that is confirmed, they are able to come off therapy and be monitored with MRD. And what we saw from this study is that the majority of patients achieve MRD negativity, of overall 80%, and that proportion was essentially the same no matter if the patients had no high-risk abnormality, 1 high-risk abnormality, or if they had ultra high risk disease with 2 or more high risk abnormalities. When you look at chances of progression-free survival, we get a slightly different story. You know, patients with high risk or standard risk did essentially the same, excellent results. But because of the design of this study that will intentionally include more high-risk patients, we end up with 24 patients who have ultra-high-risk disease. Those are people who are often very sick that would not be included in most clinical trials, but we had a very liberal eligibility to be able to capture those patients. And you see that those patients are still having relapse and progression at a higher rate than we intended, even without this therapy. So that tells us some very important stories. So maybe now that we have better therapies, the dividing line is not between standard and high risk anymore, is between standard plus high risk and the ultra high risk patients. And those are the ones who need the most attention. So in the future, we're going to be using the notion of dynamic risk assessment. Risk is not something that you have at the onset of the myeloma, and you're always going to be high risk, always going to be standard risk. That risk is amenable to be adapted, depends on what treatment you receive and how well you respond to that treatment. There are several trials that are intending at using earlier, newer agents early on, including CAR T-cell therapy or bispecific antibodies, to try to modify the natural history of the patients with ultra-high-risk disease. So in summary, there's an imperfect definition of high-risk myeloma. FISH is the most uniformly used criteria, and amplification of chromosome 1q is becoming a bigger problem. Those patients should be treated with a combination of proteasome inhibitor, immunomodulatory agent, and a monoclonal antibody. We should always consider those patients for transplant, and even consider tendon if you still have detectable disease after the first transplant. And knowing that the depth of and the sustainability of the deep response might overcome the prognostic impact of high-risk FISH, okay? Patients who still have disease detectable despite all this should be considered for double maintenance with a proteasome inhibitor like Velcade or Carprolis and an immunomodulatory agent like Revlimid. However, on the patients who are MRD negative in more than one occasion, maybe they should not be looked at as being high risk any longer, and they are candidates for even treatment de-escalation. And I'm sorry that I exceed the time a little bit, and I'll be happy to take questions.
No, it was great. I really appreciate your presentation, and I think it was an excellent summary of treatment options for high-risk multiple myeloma patients who, as you mentioned, are sometimes in the greatest need of quickly knowing which treatment's going to work for them. I have several questions for you, and we're getting several questions in the chat as well, which is exciting. One of the first questions that I wanted to clarify is in the beginning when you were talking about defining high risk, and I know that there's different definitions, which makes this more complicated. Let's talk about two different scenarios. One of the scenarios that you discussed was that perhaps we might consider them high risk if they're not easily achieving deep or complete responses. One of the questions here was, are you referring to a literal complete response, as in if they get very good partial response or partial response, frequently we'll consider them high risk? Or are you talking about if they're not achieving MRD negativity, then we're going to consider them high risk?
Yeah, you know, that it really depends. I think the more sensitive that the definition is, the better job it does to separate prognosis. So yes, you know, getting a VGPR is not as good as getting a CR, but getting a CR that is still MRD positive is not as is much closer to getting a VGPR than it is from getting a CR that is MRD negative. So if I had to test, you know, pick one test to appraise the quality of response, so that would be MRD.
Interesting. Okay, thank you. And then a different question about the ultra high risk diagnosis. Let's say that somebody has quite a few comorbidities or are old and considered fragile and have one, instead of double hit, just have one high risk cytogenetic. Would you still classify them as ultra high risk because of their physical disability or capability?
That's a great question. I totally understand the spirit of the question. But I think by now the notion of ultra high risk is really based on the biology of the disease itself. That being said, that would be a patient of concern because you have at the same time high risk abnormalities and you have difficult tolerating therapy, you know? But the answer to those problems may be very different. I mean, a patient who has high risk because of frailty, the answer is not a more intense therapy, you know, maybe a different therapy or a therapy given for longer, as opposed to a young fit patient who has biologically ultra high risk disease that we might try to overcome with additional therapy.
Yeah, more aggressive treatment that maybe the others couldn't take. Yeah, that's a great point. Thank you. Let's talk about the master trial. Fascinating work, and thank you so much for all that you're doing in that field for multiple myeloma patients. Was that for newly diagnosed multiple myeloma, or was it for relapse refractory?
No, good question. Thank you for your kind comments. That is for patients with newly diagnosed multiple myeloma.
Okay.
And that being said, I mean, do we oftentimes you know, that the population of newly diagnosed myeloma that enter trials is a little bit different from the real life. Because if any of you who have participated in clinical trial, you know you have to meet a series of eligibility criteria. So if you present with poor kidney function because of the myeloma, you're often excluded from clinical trials. Or if your performance study is not good because you're hospitalized with a fracture, you have pain, you're excluded from clinical trials. And you know, if you talk about a trial that has transplant, you know, in Europe, if you are older than 70 and someplace older than 65, you just don't get a transplant. You're excluded from that trial. So when we designed this study several years ago, we want to reflect the real life as much as possible. So we did not have an age limit, and we allowed patients to have one cycle of Velcade, Cytoxan, dexamethasone before entering. Why do we do that? Because that's often the regimen that we give for people who are very sick to get out of the woods. Somebody is in the hospital with renal failure, just diagnosed with myeloma. We usually give their regimen because it's 3 drugs, can be given promptly, is inexpensive, and oftentimes get people out of the woods and that they can go into a more outpatient treatment. So there's easily 20-25% of the patients on master that would be ineligible if they had not been allowed to receive VCD. So because of that, we had like 25% of patients who were 70 or older. We had patients as old as 78. So it's intentionally, and at some point we enrich for high risk. In other words, we stop accruing patients with standard risk disease and only accrue patients to meet a certain minimum of patients with high risk, just because we need and we wanted to learn more about those patients. That's why you see some of the numbers you see.
Awesome. Thank you so much. I have a question regarding Daratumumab, and maybe even in your personal clinical experience, what you've seen when it comes to, I'll say, variants of the disease. I'm not sure if that's the correct word, such as extramedullary, PCL, even non-secretory light chain. Do you see Daratumumab having successful results in these populations of patients?
We do. Those patients, patients with those features, they're going to have not as good response as patients without those to any therapy.
Yeah.
But yeah, so we see those patients respond to Daratumumab as well. Nowadays we hardly ever use Daratumumab as a single agent, usually using combination. And we see patients have a great response despite presenting with those high risk abnormalities.
Thank you for that. Lynette is wondering about the use of daratumumab in maintenance therapy. What have you seen in your personal clinical experience for high
So
risk?
that's a great question. Daratumumab in maintenance is one of the most controversial points currently in multiple myeloma, and I'll tell you why.
Mhm.
The Cassiopeia trial compared VTD with Dara VTD, followed by transplant, followed by 2 cycles of consolidation. And after that, patients were further randomized to no maintenance or maintenance with daratumumab. Okay.
Mhm.
So let's understand what happened. So the patients who received no daratumumab as part of the induction and consolidation, so patients got a VTD, transplant VTD, and they received daratumumab, they had a tremendous impact on the risk of progression. They had a 70% reduction in the risk of progression or death. So you can say, daratumumab is the most active drug in maintenance ever tested. However, the patients who received daratumumab during induction and consolidation did not get any further benefit by receiving daratumumab as maintenance. Okay.
Interesting.
And that is so far. Now, this data can mature further. In the United States, oftentimes people don't relate to that data because the standard maintenance in this country tends to be lenalidomide. So there's 2 trials now that try to answer that question. One trial is the SWOG 1803. It's a large national trial with literally thousands of patients, where patients are randomized to Revlimid or Revlimid plus daratumumab. And after 2 years, if they are MRD negative, they're randomized to continue what they're being on or stopping. The other trial is called Auriga trial. That trial is for patients who have finished transplant and they are MRD positive. And they are comparing Revlimid with Revlimid plus daratumumab. Okay. The Griffin study that I show had also, patients received Dara VRD and they went on to receive further Dara Rev for 2 years, or VRD and they went on to receive Rev for 2 years. And on that study, you see some improvement in the depth of response, more patients reaching MRD negativity with the daratumumab continuing after induction and consolidation. So I would say at present time, it's uncertain. I say it's a valid option for patients who have not received daratumumab as part of the induction and consolidation. But at this point, it's not an approved indication and is a path that very few people take.
Yeah. So if somebody were, for example, to be responding well on a different maintenance therapy, it's not like you would recommend, also add daratumumab.
No.
Okay. Good. Thank you for that clarification. Lots of great questions here. Another one of the questions that I had that I see repeated here, and now I just lost it. Okay, let me pull that back in just a minute. Robert's wondering if you could expand a little bit further on your recommendation of MRD rather than just trusting that stringent complete response result.
Yeah, so that's unfortunately I don't have a slide to show on this deck, but there's some very good and mature data from several data sets, but one particularly from the Spanish group that shows that if you follow people over years, the patients who have CR, they do better than people who have VGPR or PR. That's the fact. But when you go and separate those patients who had CR and those who are MRD positive and those who are MRD negative, you see the CR with MRD positive, they pretty much overlap with VGPR or even with PR.
Mm.
And the really ones who do really well, that what gives CR a good name is that embedded in CR, there are patients who are MRD negative. So what carries the good name for CR is that embedded on that are patients who are MRD negative. I mean, I'm not saying that everybody needs to become MRD negative. I'm not saying that you have to become MRD negative to be successful and live long term. Every time we discuss MRD, somebody brings up an example or two of a patient who never achieved CR and is doing great after 10 years. There's never one statement that fits every single patient. But in general, the best prognosis is among the patients who become MRD negative. If you are changing CR, there's a good chance that you're MRD negative as well, but it's not guaranteed. So I would say, I'll tell my patients, if I ever going to do a bone marrow after starting therapy to assess the response, it doesn't make sense to not do MRD, because that's the most informative things you can learn from that bone marrow test.
Yeah, definitely. Thank you. And that reminded me of my question that I was going to ask. I learned earlier from Dr. Tricot, he was talking to me or talking to the group in his presentation about how in his experience, 11-14, though it's standard risk, he had a hard time getting the 11-14 patients into MRD negativity. They stayed kind of standard MRD positive. That just made me wonder, and maybe this can't be answered, but is it easier because of the aggressiveness of the treatments for the high-risk multiple myeloma to get high-risk patients into MRD negativity, or because does the cytogenetics kind of balance it out? Do you know what I'm trying to ask?
Yeah, that's a great question. And I think the answer to that, it depends on therapy. So in general, you're absolutely right. I mean, it's patients with high risk disease are less likely to become MRD negative. But that always in the area of transplant and with alkylators and proteasome inhibitors and needs at most. Now, you see it by adding Daratumumab, or as a matter of fact, Isatuximab as well, to the initial regimen, you're more than doubling the chance of getting MRD negative. So that's really changed the game. And what we saw on MASTER, for example, is patients with high risk, they become MRD negative as at the same rate than the standard risk patients. The challenge was really those patients with ultra high risk. They took longer, and their MRD negativity was less sustained than the standard risk. But I would say patients with a single 414 translocation, they didn't seem to be any more difficult to achieve MRD negativity than in this day and age with the present type of therapy.
Awesome. Thank you for that response. A couple more questions, and then we'll finish up for today. One of our patients is asking if you can expand a little bit more about the 1Q gain, the controversy that's I don't know if controversy is the right word. The questions that are arising concerning high risk surrounding that cytogenetic, and what your personal opinions are on that.
Sorry, do you mind framing that again?
Yeah, I framed it confusing. So in the beginning, we talked about how 1Q gain is one of the cytogenetics that, if I'm remembering correctly, that there's a little bit of controversy around whether it's high risk or standard risk. What would be your personal opinion on what you've seen and heard and collected?
I think it's becoming very clear now. I think the reason why 1Q was not claimed as being high risk, in the earlier work with the fish, is because was not looked for. Fish is not a CAT scan that you get everything and you see what's there. You have to go look for that particular abnormality. And as the fish panels start to include probes for 1Q, it became clear that it was very common, and it carries a bad prognosis. And It's a little bit more nuanced than that because you can have one extra copy of 1q. No, normal person will have, a normal cell will have 2 copies of 1q, right? One in each chromosome 1. If you have a third one, is bad, but not so bad. But if you have 4 or 5 or 6, we'll call amplification. That's where really the badness is. And it goes back to the point I made early on that, prognosis is very context dependent. 1950s, anyone was high risk. And I think, things that are like 414 by itself, nowadays, maybe it doesn't matter a whole lot with proteasome inhibitors and monoclonal antibodies. But 1q remains. We saw on the Forte study with KRD, Transplant KRD, that was the group that had the worst outcome and had the least improvement with transplant. On Master, all the patients who had early progression, people who progressed, whose myeloma got worse while receiving 4-drug therapy, were all patients with 1q amplification and concomitant p53 deletion. So I think it's the landscape of risk assessment is changing.
Yeah, definitely. And I appreciate your clarification because one of our patients was reaching out saying they were told it was they would still be considered standard risk, but it looks like they didn't have the amplification. So that's a great distinguishing factor there. Thank you. The last question is from Doreen, and she is wondering, is elotuzumab similar to daratumumab? And what do we know about it?
So elotuzumab is a different antibody. It's also a monoclonal antibody, but has a different target called LAM-F7, as opposed to daratumumab and isatuximab that have the target CD38. Elotuzumab has been shown to be helpful in relapsed myeloma in combination with Revlimid or in combination with Pomalyst. But it has not been shown to be helpful in newly diagnosed myeloma. It has been at least 2 trials, including one trial run by my colleague Sadus Bunny through the SWOG, where patients with high-risk myeloma receive either KRD or KRD plus elotuzumab, and there was absolutely no difference in outcomes.
Interesting.
So I would say it's a drug that's still there, has some value, sometimes we use, but has really a limited role in patients with high-risk disease.
Interesting. Thank you for that. I see lots of comments here about more questions about MRD, and I know that it can be confusing. I will attach, we have a couple recordings from other doctors who got to spend more time about MRD just so that our audience can get more information in our follow-up email that we will send.
That's a topic that is very close to my heart, but it's a topic on its own, It's
definitely.
Another hour.
Definitely. We might have to have you come back a different time to talk about it, Dr. Costa.
It'll be a pleasure.
Last but not least, Steve Morris and his wife Judy just want to say hello, that he's still MRD negative and that they're your number one fans. So
nice to hear from you. I always enjoy to hear from you.
Yeah, wonderful, Dr. Costa. And I apologize we didn't get to all the questions today, but I appreciate everyone's participation. Thank you for taking the time, Dr. Costa. We appreciate you.
Absolutely. Thanks for the opportunity, and a good night to everybody.
Good night. You're welcome to sign off. I'm just going to do a couple of outro announcements for the group, but thank you for your time. You will want to join us next month or 2 months from now in May. We're going to be talking about Know Your Myeloma Therapy, and we're going to have a multiple myeloma specialist come talk us through Pomalyst or pomalidomide. Learn more about this commonly prescribed drug, its mechanism of action, side effect profile and management, and common combinations with us in our next meeting. And there's more details to come soon. You may be interested in other Myeloma Crowd community events we have coming up. On the 16th is the Mountain West Myeloma chapter. That's tomorrow, and we're going to be hearing a story of hope from myeloma patient James Bond. And yes, that is his real name. And yes, he was clinical trial patient number 007. So you'll want to hear from him and his inspiring story of 4 stem cell transplants and how he accredits his fitness to being alive today. The 17th at 1 p.m. Eastern is our MGUS Smoldering Myeloma Patients chapter, and we'll be hearing from multiple myeloma specialist Dr. Tax Corrales as he shares his opinion on will the smoldering myeloma diagnosis phase out, leaving us with just MGUS and active myeloma. And if not now, could that be possible in the future? On the 22nd at 6:30 p.m. Eastern, we invite you, if you're living in the Florida area, to join us for the Florida Myeloma Crowd Community Chapter launch. We're really excited, and I've had a team on the ground working hard to make this happen. So please join us if you're from Florida or in Florida and want to be part of this Florida Myeloma Crowd community. Another thank you to our sponsors, Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnologies, Sanofi, Janssen Oncology, Karyopharm Therapeutics, Takeda Oncology, and AbbVie. Thank you to each of you for taking the time tonight to be with us and for participating. I appreciate you, and thank you for helping us build this strong myeloma crowd community. I hope that you have a great rest of your evening or your day wherever you are. Take care, everyone.